First of all, let me introduce our team. Joni sir is our head of the department. I work as cardiologist here under Joni sir. Dr. Vishnu is consultant cardiologist here. And our team members, they are all there inside. And firstly, I would want to thank Dr. Kapardi. He's got immense experience in orbital atherectomy, OCT and all. He's also a CTO operator. Without any hesitation, he agreed to join us today, tomorrow. But I told him tomorrow at the earliest, whenever he wants, he can be back to his native place. Sunday he has to be in his home. So whenever it's convenient for him, he'll be traveling back. So whole throughout the day he'll be here with us. So thank you so much, sir. Thank you so much for joining us. Then what we thought is we have almost 6 cases lined up today. All calcium contamination and bifurcation and some left main ostium, things like that. So we have almost 15 of you joining us today for the session. So we'll have the 7 coming inside. So that initial first case, 7 of you can join with us. So whatever we are doing there, it's all live, can be seen live over here. So we start with 7 of you inside the cath lab. Then the next case, the second half can join us inside. So initially we start with 7 of you coming inside the cath lab for the first case. So that's what we decided. So initially we planned in such a way that we'll just have 3 cases. But then because the number of cases are more, we'll try to cut short the number of presentations today. But certainly we'll start off. I hope you are all used to OCT, right? OCT, most of you are used to it. So there is no point in starting off with an OCT morphology presentation. We'll start off with the basics of orbital atherectomy by Dr. Kapardi. And once that is over, we'll start off with the first case, and in between cases probably we'll have short discussions over here. That's what we'll do. So with this I would want to thank you all once again, and Team Abbott for the immense support from their side. Arun, Soju, everyone, Kalyan also has joined us. So I hope Subodh will be coming, is it? Not sure. Okay. So I'll hand over the mic to Joni sir for a word of introduction, and after that we'll start with Kapardi sir's talk on orbital atherectomy.
I am here to join Deepak for the warm introduction. So first of all, again, thanks for coming from far and wide parts of the country, including experts who are then people who are keen to learn the cutting edge, as Deepak has said. So I don't want to waste any time. Have you anybody new to this Kottayam Central Kerala area? Raise your hands. There are. So anybody who wants to, even apart from the academics, you want to have some fun or something, we have plenty of places here, Kumaragam. So somebody, even though you are in a busy schedule, having a break like this is a good thing. So just these few words, I especially welcome you, Kapardi sir. I have seen you in operating in the conferences. We are all blessed to have you with you. So thank you all.
Okay, so these are the important components. So if you are familiar with RotaPro, almost the Diamondback coronary atherectomy device will be like a RotaPro. You can see actually, and these are the different components. Yes, this one point. Okay. So these are the different components. If you can see here. So okay. So this is the one which is a lubricant. It is a white milk like will be there, unlike a Rota solution. So this is a orbital atherectomy solution. This is a lubricant in a bag. You should dilute in the saline. And this is the motor pump which will push the fluid. And this is the one which is the main device, orbital atherectomy device. So which consists of entire thing is hand driven actually. And this is the Viper advanced wire. The basic difference between Rota wire and Viper wire is Rota wire is a steel wire, whereas the Viper wire is a hydrophilic coating nitinol wire. So rotawire is difficult to navigate. Of course, nowadays there are some recent advances is there in rotawire, also rotapro wire, rotaglide wire it is coming. Here the basic nitinol, so it will cross the tortuous as well as micro mini channels of the coronary lesions. That's the advantage because of its hydrophilic nature and nitinol nature. And it is kink resistant. Once nitinol means kink resistant, unlike a steel wire. So these are the advantages of the Viper wire. Even without exchange, you can pass this Viper wire across the tight calcific tortuous lesions also. So with this, these are the components and how we have to set up the device. Just I will show. In 2 minutes you can set up.
To begin setup,
First you have to prepare the saline mixture.
Draw 20 milliliters of Viperslide lubricant solution from the lubricant bag and mix with a 1000 milliliter bag of normal
You have to
saline.
dilute the saline. Yes.
Using sterile technique,
Then this is the second one, preparation of the Viper wire, guide wire.
Contains the guide wire. Remove the guide wire. Use care not to stretch or damage the distal spring tip when removing from the packaging. Using sterile technique, the setup takes
So
less
this is the
than
third
2
one.
minutes.
The pump we have to set up
Use the
or the saline
screwdriver
stand.
to attach the pump to a standard IV hole, no higher than 60 inches, 153 centimeters from the floor. The setup takes verify that the power
This is
cord
it.
is
You have to
connected to the
attach
back of the pump. Plug
the power plug
cord into a
to the
properly
pump.
rated hospital-grade power outlet. Verify that the power cord is connected to the back of the
This is
pump.
more important.
Plug the power cord into a properly rated hospital-grade power outlet. Press the master power button
Then
and check that the red
pump
or
you have to
yellow
activate
LED is lit on the pump
and check by
controls.
means of red signal.
Press the master power button and check the move the sterile tubing
The
from
next
the
step
OAD
is connecting
package
this
and
device
pass
to the pump.
tubing, spike end out from the sterile field to a non-sterile team member. Connect the saline line to the
This is
OAD
important
saline connection.
Bubbles
The
should be
non-sterile
to
team member
deaerate.
performs the following steps. Sterile tubing from hang the prepared bag of normal saline solution with lubricant from the low saline
set up
level
of the
sensor.
bag with lubricant.
Connect the saline tubing to the saline bag using standard hospital procedure. Ensure that there is slack in the tubing between the pump and saline bag. The prepared bag, open the pump
This is
tubing.
everything. So you have to put
Place
the
saline
tube
tubing
in the roller
into
pump.
the groove guides of the roller pump.
It will monitor the
Close
speed.
the roller pump door. Verify that the saline tubing is not kinked or damaged and that the tubing is properly inserted into the roller pump. Open the pump tubing. Connect the OAD
Next
power
step is
cable to the pump.
Purge the air and
Next,
pump starter.
Purge air from the OAD. Press the green start button
That is start
and check
button.
that the green LED is lit. Connect the OAD power cable to the pump. Next, purge air from the. Press and hold the prime
This
button
is
on the front of the
The
saline
blue
pump
is
or
priming
on the
button
OAD
actually. You have to press
purge the system.
to purge the saline.
It will pump saline at an increased flow
This
rate
is the
as
clear
long
air
as the
bubbles.
prime
To
button
clear
is
the air
held down.
bubbles.
When the prime button, before inserting any portion of the OAD
This is
into
important.
the
You have
pump,
to crown
ensure
advance.
that
You have to
axial
check.
movement of the crown advancer knob will produce smooth travel of the crown. Note, do not activate rotation of the crown during
By
this
testing,
test.
actually, you should not activate.
Before insert, ensure that the crown advancer
Then
knob
axial
is in
rotation.
the unlocked position,
Yes.
allowing free axial
Vertical
travel
means
of the
unlock.
crown advancer knob.
Horizontal
While
means
visually
lock.
monitoring the crown, slowly move the crown advancer knob in a back and forth motion. Ensure that the crown advancer knob, after testing the crown advancement,
This is the
test
test
the crown rotation.
away from
Move
the
the crown advancer
cloth
knob
like
fully
rotablation.
away from the nose of the handle and release the guide wire brake before
This
threading the
up
guide
is the
wire through the shaft.
and the
Grasp
brake
the
release.
proximal
Down is
end of the
brake.
guide wire and thread it through the hole in the shaft tip
Not advanced.
distal to the crown. Continue feeding the guide wire into the shaft until the guide wire appears at the rear of the handle. The OAD should not have passed through the hemostasis valve at this point.
Yes.
After testing the crown advancement, ensure that the brake is locked
This is the
as
one.
the crown
You have to
will
check
not
the brake.
spin if the brake is open.
And check the saline
Verify
flow.
that saline is still flowing freely and check the saline tubing and connections
And
for
saline
any leaks.
leakage also you have to see.
Note, Ensure that the rotating portion of the OAD will not contact any body
Same
parts or
like
fluid.
rotation.
Ensure
Rotor
that the
flow.
brake is locked, as the crown will not spin if the
Yes.
brake is open. Verify that press the on-off button
This is
located on
like
top
a
of the
Rotor
crown
Pro.
advancer knob
On
to
button is hand
activate
on.
crown rotation. The OAD is preset to low speed, and the LED will indicate the low speed is selected. Check that the flow of saline has increased and that the shaft and crown have begun to spin. Immediately press the on-off button again to stop rotation and complete the test.
That's all. This is the checking the rotation. That's all. And there is basically 80,000 speed and 1,20,000 speed should be there. Always the safety one is 80,000 speed you have to keep. And if the vessel is large size, 3 plus, then you can use the 120 speed. But always the safety for the orbital retro sanding, you can put 1,20,000 speed, which is safer compared to the anti-grade sanding with 1,20,000. Always safer is 80,000. There should be 3 criteria. The vessel size should be more than 2.5 and less tortuous vessel. That is more important. These are some of the safety tips of the orbital atherectomy. Okay.
There's nothing like a huge console. It's a very small thing. You call it as a pump. It does just 2 things. One, you connect the electric cable over here, and secondly, through this, the saline has to come through to the device. There are 2 things. That's the only advantage of having this particular device. So that's known as the pump. This is basically the investment that we have to make in the hospital. And then regarding this, can you give me a head mic? So basically we know about the pump. The advantage of having the pump is basically 2 things. One, this is actually the device. You call it as a handle, or you can compare to rotor, you call it as the advancer. Here you call it as the handle. So again, you have a motor inside this. There in the rotor, the motor is activated by the air coming in. Pneumatic way of activating the motor. Here it's an electrically driven motor, so it's more simple because you have only 2 speeds, 80,000 or 120,000. There you can adjust the speed, 80,000, 180,000, 170,000, 160,000. That way you can activate it. But here you do not have to activate it that way. You just have only 2 speeds, 80,000 or 120,000 RPM, and so that motor is activated by this particular cable. So you connect this cable to the pump. So that is one way of looking at it. And second thing is you have to have the saline flowing in. So this is the tube for the saline. So through this tube the saline flows into the coronary artery through the sleeve. Okay. So basically you have a drive shaft. This is known as the drive shaft. At the tip of the drive shaft you have the crown, and this drive shaft is encased inside this particular small sleeve. This is a sleeve or a sheath. So whatever saline you infuse, it comes through this sheath into the coronary artery near the lesion. So whatever you do, burring, whatever atherectomy is done, whatever particles are created, it's typically said that all the particles are only 2 microns in size. So the particles, it washes away with the help of the saline. So you have these 2 connectors. One, the electric connector for the motor to be activated, and the second one is over here. This is connected to the pump so that the saline infusion the speed can be adjusted with the help of this. So you have two connections that goes to the pump. Now then coming to this particular thing, that's the handle or the device, and here you have a lock. This is a brake. So that once you have the wire going into the coronary artery, unless and until you apply the brake, the wire also can spin. The wire also can move axially in and out of the coronary. So you want to prevent that. So during the crown rotation, during the atherectomy, you always lock it. So that it doesn't move. Now taking out the crown from the wire from the coronary artery, you just have to unlock it. It's a very simple thing. Once you start burning, always it has to be in the lock position. Unless and until it's in the lock position, you cannot activate the motor. So you cannot activate the crown. So that's a very, very simple thing. So even if you forget to press the brake button, it won't get activated. So obviously you'll have to do that before you start burning. So that's the brake button. Then this is primarily the drip and all, and these are the two things that is trying to achieve the 80,000 speed or 120,000. You press this, you get 80,000 speed. You press this, you have 120,000 speed. That's for this particular thing. And then coming to the advancer knob. So this knob would help you to move the crown forward and backward inside the coronary artery. So that's the crown moves forward. It's very similar to rota. You just have to move it forward and backward. But then here the speed is very, very slow because it has to stay at a particular place for proper sanding to happen, proper polishing to happen. You have to have the crown staying at a particular place. So you cannot just move it forward and backward. But then in our experience, when you have a difficult lesion, it always jumps forward, it jumps backward. It always tends to happen. But then at the back of the mind, you need to keep it in such a way that it has to be 1 millimeter second. It has to be very slow, not like picking, moving forward and backward aggressively, that sort of things like what we do rota. It shouldn't be done like so. That's a knob control. And then starting the motor, that is activating the crown, would be pressing this. It just activates. Now you can move it forward and backward, do the ablation, stop it, and then pull it back. It's as simple as that. It's not very technically challenging. Something similar to, it's not something similar to rotablator. It's technically much more simpler. So this basically the device as such, and there are few other small things to be learned. That probably we'll learn it during the procedure also.
Some safety techniques which we can use during the procedure will tell. Depends on your patients. No. Actually, everything you have to go very 1 millimeter per second you have to go. So your length of lesion will determine ultimately how much time you have to spend. And another advantage is you can do retro sanding also, like anti-sanding. You can same time for the retro sanding also you can do. That's the advantage of that road. Yes. Okay. You can stop there. Yeah. That's the advantage. Yes. No. Still it is a lesion is there, we can progress. Yes, in the lesion also you can stop because it won't block the flow. Unlike rota. Rota is 1.5 bar will create 1.5 lumen only. Whereas because of its axial rotation, not only forward, backward movement, it's axial movement. So with this axial movement, what happens is it will increase the lumen width. Usually 80,000 speed, 2.5 millimeters. The minimum area you can gain is 1.9 square millimeters. 1.9 to 2 square millimeters you can get in this bar. For larger one, you have to increase the orbit size by 120 speed. Then it will increase the orbit for left mains and the osteoproximal ladies where the size is more than 3. You can use 1,30,000 speed. Balloon? Yes. On. Yes, it will cross. That is the advantage of atherectomy. Atherectomy devices basically it will convert the uncrossable to crossable lesion by ablating the protruding calcium into the lumen. That's the purpose of. And another advantage of OA compared to rota is rota won't affect the wall calcium. Whereas this orbital atherectomy, by means of its orbits moving, it will cause the wall calcium as well not only nodular calcium, but also the wall calcium it will also ablate. But you should have a lot of patience. If you can spend 20 minutes, yes. And some of the operators know, because when we started the program 1 year back, the German, they came proctors. Northeast countries, especially some of the cardiologists, they will do the sanding with the orbital atherectomy, systematically spending more time. Then you can have a maximum luminal gain. Then they can do just stenting like that, because the wall thickness will come down as you are spending more and more time, more and orbits anti-retro. Then automatically, ultimately what is the mechanism of balloon angioplasty? With the dissections, you understand, by producing dissection, stitching. But here, by sanding, it will reduce the wall width. You understand? The thick plaque wall becomes a thin plaque wall. Another advantage of orbital atherectomy is it produces Mullins effect. Mullins effect means because of its orbital movement, it will stretch the wall by pulsatile centrifugal force. It will hit the wall like this. Stretch. So previously the stiff, non-compliant vessel becomes a compliant, stretchable vessel. You understand? The IVL mechanism is different. IVL mechanism, by producing macro and micro fractures of the wall calcium, it will becomes non-compliant vessel wall become compliant one. Whereas this, not only it increase the luminal gain by means of sanding, by reducing the plaque volume or by reducing the volume of the calcium or plaque, and it will produce centrifugal force and pulsatile, that is called Mullins effect. Actually, one of the scientists, he did the experiment with the in vitro vascular models between rota and orbital. The orbital, the luminal gain is by means of reducing the volume as well as the Mullins effect by means of centrifugal pulsatile forces. The non-compliant vessel wall become compliant. So you can gain much more luminal gain. That is the fundamental difference with the orbital and the rota. I think got the point. Here the penetrating forces, it is not the penetrating force, it is the atherectomy actually. Both are atherectomy, but only thing is yes, both you can do, but only the luminal gain with orbital atherectomy is more. No better, both are same, but only the luminal gain is more with orbital atherectomy compared to this one. Yes, both are same. No penetrate. Here the only thing, yesterday I discussed with you, the non-crossable lesion or high resistant lesions becomes less resistant when you add the kinetic energy to the object which you are going through it. Understand? So by means of its kinetic energy, what it will do is it will slowly sand and it will go. But only thing is, whenever a bend lesion is there, you spend some time. Don't be hasty by pushing. So automatically by means of rotation with a slow movement, it will automatically go. Uncrossable become crossable. And the volume it will reduce. No, it will ablate all types of calcium, nodular calcium, superficial calcium, eccentric calcium, wall calcium, all varieties it will do by means of axial movement. No, boss, just 1 minute. We have experience. Actually, like coronary calculus like structures also, what theoretically, yes, but practically it will cause. It is possible. We have examples, case examples are there. Yes, correct. Yes. Yes, correct. Yes. True. That is the major limitations. If hemodynamic compromise, you have to shorten the time. This is not a suitable. It is just like a tortoise. Sure. Unlike rota, the jumping movement won't occur with orbital. Sorry to say, except in bends. In the bends, that's why when we started our program, we luckily we have difficult cases when we started. All bend lesions from left main to circumflex and circumflex to one jet-shaped bend, and they told very cautious. You should be touch and slowly movement. In spite of so, the jump compared to rotation atherectomy is very least, because here the movement is very slow. There it is fast. So the jump is long with rota, where sometimes perforation occurs always slow. Here it is very slow. The jumping is very minimal at the bends. But for nodular lesions, jump I have not seen. That's the advantage of this.
Particle size is significantly less with orbital compared to rota. And secondly, it is said that when you do a rota, when you hit hard at a lesion, it obstructs the flow inside the coronary. But here it's an eccentrically mounted bar. You always have continuous flow into the distal coronary. So even if you have little bit of particles formed, it just runs away through the microcirculation. Wherein the other one, it just hangs at the lesion, and when the bar is pulled back, it just moves it forward. So the chance of the particles going and occluding the microvasculature would be more with the rota. So these are the two examples, the reasons why probably the slow flow is less with orbital compared to rota.
This is important, but the phenomena we observed, even no flow, slow flow, but incidence is very low. Occasional case waves. Yes. No, they are all complementary actually. They are all complementary. All the devices have their own advantages. You have to correct switch, correct plug. That's it. Yes. Sir. Any bends are there? No angulations. Yes. Okay. Yes. To be frank, you are not patient. That's all.
Even if the end balloon doesn't cross, you could reach out to rota. Because it's a... And again, say basically it's not a front cutting device. It's not a front cutting device. So primarily, so we always theoretically you can have a situation wherein when you have a difficult lesion, it may not cross, wherein the rota would cross. you can have a situation like that. So if it doesn't cross, and if the balloon hasn't crossed, what would have been your option then? Rota, obviously rota. So there are, so this has advantages like the luminal gain can be better, the slow flow can be better, but there are situations it has got disadvantages also. So all these things you need to be well versed with both the modalities.
Yeah. 2 days back only we did that. Actually, the routine wire did not go. So I have to take a taper tip filter XT wire and the cross wire. And the microwave wire did not cross. Then I took the low intensity profile caramel and crossed that one. And then exchanged with the wiper. Then it went to this one. I spent more time and it comes.
That's the greatest advantage. There are situations wherein, but nowadays in those situations when the microcatheter doesn't cross, we just take a laser catheter and go across. So then the microcatheter would move forward. But then when you do not have laser, the option would be to keep the microcatheter snugly into the lesion, remove the workhorse wire and go with the wiper wire. Wiper wire is much more steerable, because it's got whatever is available here. That's the flex tip, nitinol coated one, nitinol core wire. So then you have two advantages. One, it's easy to cross through a difficult lesion. Second, it also retains the shape. So then once you do the LED, you can go into the circumflex with the same wire. So these are two advantages of the orbital atherectomy, the flex tip wire, the new one. The new one is only available right now in India. The old one is not available. So the nitinol one, the flex tip, so then it's a much user-friendly wire compared to the older one. Again, it's a differential cutting. That's what it says. See, it does the sanding. Obviously, it's anybody's guess. It could damage the intima. It could damage the intima because you have some protrusions on the wall. When you do the sanding, it can mildly damage the soft tissue also. So every time we do an OCT,
no, that's why I'm telling. It is a sound actually you have to hear. The damping sound means it is ablating the plaque, sanding the plaque. Once damping sound becomes a normal routine sound of its own frequency, that means adequately shaped. It is the sound which and the movement. These two audio-visual coordination should be there. Adequate sanding was not done or not. And that's why less than 2.5 won't take. Because that you told that potential problem of perforation is that. And also other thing, unlike rota, which you can do secondary. After balloon dilatation, still it is there, you can do. But orbital, once you produce dissections, you should not use. Because the basic fundamental atherectomy is only, it will luminal, not wall rota. Whereas here, the wall also it become weakens. Already dissections become weaker. With this, the centrifugal, it will cause perforation. That's it.
We are ready with the first case. We can have discussion whole throughout the day.